Red and white lesions of the oral cavity, part 2. Etiological classification of the red and white lesion include premalignant lesion and premalignant condition. Under premalignant lesion, leukoplakia, lichen planus, like node reaction, drug-induced graft versus host disease, erythroplakia, actinic keratosis, discoid lupus erythematosus, chronic hyperplastic candidiasis, premalignant conditions, oral mucous fibrosis, disc keratosis, conjunctiva. Leukoplakia. Who defined the leukoplakia as white patch of plaque that cannot be clinically or characterized clinically or pathologically as any other disease? The etiology of leukoplakia includes tobacco products, which is smoking, ethanol, alcohol, hot, cold, spicy, acidic foods and beverages, alcoholic mouth rinses, occlusal trauma, sharp edges or prosthesis of the teeth, actinic radiation, syphilis, presence of Candida albicans, presence of virus. Leukoplakia commences as a protective reaction against the chronic irritant. Clinical findings: the prevalence rate is 2.6% over 50 years of the age in male. Asymptomatic, most common, occurs in the vermilion border of the lip, buccal mucosa, mandibular gingiva, tongue, floor of the mouth, hard palate, maxillary gingiva, lip mucosa, and soft palate, floor of the mouth, and lateral borders of the tongue are high risk sites of malignant transformation. The classification includes homogeneous leukoplakia, non-homogeneous leukoplakia. Under homogeneous leukoplakia, it is completely whitish lesion which is flat, which has a spoon surface or either corrugated like a beach at ebbing type, pumous like with a pattern of fine lines, wrinkled like a dry cracked mud surface. Under non-homogeneous leukoplakia, we have a types of nodular or speckled leukoplakia where white specks or nodules on the erythematous base, verrucous leukoplakia where slow growing papillary proliferations above the mucosal surface that may have a heavily keratinization. Extensive lesion of this type is called as a oral florid papillomatosis. Ulcerated lesion where it exhibit a red area at the periphery of the white pictures at the present. Erythroleukoplakia. Leukoplakia is present in association with erythroplakia. These are the forms of leukoplakia. The diagrammatic illustration is given below. What are the differential diagnoses of leukoplakia? Lichen planus, leukoedema, hyperplastic or hypertrophic candidiasis. How can we manage leukoplakia? For leukoplakia, topical antifungal agents must be given, which is candid green, clotrimazole thrice per day for a week. Where there is no response less than 1 centimeter, if it is less than 1 centimeter, excisional biopsy should be performed. If then more than 1 centimeter, incisional biopsy should be performed. If dysplasia is present, total excision of the lesion with graft was followed for 6 months for 3 years. If the excision is not possible, capsules of lycopene 4 mg twice a day or 8 mg once a day for 3 months should be given, or capsules of antioxidants with selenium can be given. Topical bleomycin 1% thrice a day for 15 days can be administered. If the dysplasia is present, retinol A, vitamin A analog ointment should be given twice a day for 1 month. If there is a reduction in the size, continuation of the topical antifungal agent for 1 month should be administered. Next one is erythroplakia. Definition by WHO in 1978. Bright red velvety plaques which cannot be characterized clinically or pathologically as being due to any other condition. Etiology and pathogenesis. The etiology is uncertain. Most cases are associated with heavy smoking. Majority of the erythroplakias exhibit pre-malignant and malignant changes. Erythroplakia is often regarded as the early sign of asymptomatic oral cancer. It reddish color results from the absence of surface keratin layer. Connective tissue papilla project close to the surface. General failure of the epithelial cells to achieve significant maturation. The clinical features include appears as a velvety red or granular red macule patch that may be slightly raised, most predominantly in older women in 6th to 7th decades of their life, more commonly seen on the floor of the mouth or ventral tongue, soft palate, and the tonsillar fossa, all prime areas for the development of carcinoma. Multiple lesions may be seen. The clinical features also includes erythematous plaque with soft velvety texture, asymptomatic, mostly painless, varies greatly in size and borders may be well circumscribed or may blend imperfectly with the surrounding mucosa. There are three different appearance given by shear, which is homogeneous form, red in appearance, patches of erythroplakia and leukoplakia, speckled erythroplakia or granular erythroplakia. Homogeneous erythroplakia is generally more aggressive than other forms. The floor of the mouth is most common sight in men. Mandibular gingiva, alveolar mucosa, mandibular sulcus is most common sight in women. Retromolar region is the second most common site in both the genders. The diagnosis includes based on the clinical observation of white or red patch. If trauma is suspected, sharp tooth occurs, restoration should be eliminated. If healing doesn't occur, biopsy should be performed. Histopathology shows with severe epithelial dysplasia or carcinoma in situ or invasive carcinoma. The DD includes traumatic erythema, atrophic candidiasis, purpuric macule, early stage contact allergy. Management include if the lesion persists for more than 14 days of biopsy is mandatory. Epithelial dysplasia or carcinoma in situ warrants complete removal of the lesion. Alcohol, smoking, and well-established risk factors should be discontinued. Cold knife surgical excision or laser surgery should be performed. Follow-up of erythroplakia. Re-examine the pre-malignant site irrespective of the surgical lesion every 3 months for first year. Follow-up intervals may be extended to once every 6 months. Next one is oral submucous fibrosis. According to Pinbock and Sizzat, OSMF is defined as an insidious chronic disease affecting any part of the oral cavity, sometimes pharynx, although occasionally preceded by and or associated with the vesicle formation. It is always associated with the juxtaepithelial inflammatory reaction followed by the fibroelastic changes of the lamina propria with the epithelial atrophy leading to the stiffness of the oral mucosa, causing trismus and inability to eat. The etiology of OSMF is aricanate, which has a primary etiologic factor of aricolin. Aricolin affecting the metabolism of collagen leads to increase the fibrin deposition, which cause fibrosis. Evidence of genetic predisposition is also there. Classification: Khanna and Andrade classified OSMF into different stages. Group 1, very early, mouth opening is normal, burning sensation is seen, excessive salivation is evident, acute ulcerations and recurrent stomatitis. Group 2, early cases, mouth opening is 26 to 35 mm, interincisal opening, soft palate and facial pillars were the primary areas affected. Buccal mucosa appeared motile, marble-like, where dense, pale, depigmented, fibrosed areas alternated with pink normal mucosa. Red erythematous patches can be seen. Widespread sheets of the fibrosis is evident. Group 3, moderately advanced, mouth opening 15 to 25 mm, interincisal opening. Trismus is evident. Vertical fibrous bands can be palpated. Unable to blow out their cheeks and whistle, soft palate fibrous bands were seen to radiate from the pterygomandibular raphe or the anterior facial pillars, scar-like appearance, atrophy of the vermilion border of the lips is evident, unilateral posterior cheek involvement with only ipsilateral involvement of the facial pillars, and soft palate mouth opening is reduced to 15 to 18 mm intense incisor opening. Group 4 advanced stages, stiffness and inelasticity of oral mucosa is evident, trismus is evident, mouth opening is reduced to 2 to 15 mm of interincisal opening, versus thickened, shortened and firm on palpation. Uvula was seen to be involved, shrunken, small, fibrous bands with tongue movement restricted, papillary atrophy is evident, lips circular band felt around the entire mouth, difficulty in intraoral examination. Group 5 advanced cases with pre-malignant and malignant changes, OSMF and leukoplakia, OSMF and squamous cell carcinoma is evident. Management stage 1 systemic supplements such as iron supplements, antioxidant capsules twice a day for 3 months can be advised. Topically, benzidamine mouthwash 0.15% can be given. Triamcinolone acetonide crushed with dexamethasone tablets in 20 ml of water used as a mouth rinse. Immunomodulators such as levimazole 150 mg once a day for 3 days twice in a mouth for 3 months can be given. Stage 2 and Stage 3 intralesional injection of dexamethasone plus hyaluronidase 1500 international units plus lignocaine 2 ml multiple site injections once a week for 6 weeks can be given. Betamethasone plus hyaluronidase 1500 international unit lignocaine in plus placentrix 3 ml. The multiple site injection once a week was given for 6 weeks. Stage 4 no medical treatment can be given. Surgical relieving with fibrous bands with buccal pad or fat covering the wound. Laser surgery can be recommended. In stage 1 newer drugs or pentoxifylline 400 mg twice a day for 15 days, interferon gamma injection. In stage 2 and stage 3, we have to accompany physiotherapy such as mouth opening exercise, mouth opening appliance, ice cream stick, ultrasound. Coming to the immunological disease of red and white lesions, which include lichen planus, drug-induced lichenoid reaction, either graft versus host disease, lupus erythematosus, lichen planus, chronic inflammatory disease that affects the skin and the mucous membrane. One of the most common oral disease, the exact cause is unknown, but the immunologic system plays a leading role in the pathogenesis. Etiology and pathogenesis, it is mostly autoimmune disease. The prevalence rate is 0.5 to 2.2%, most commonly seen in women than men. Mean age at the time of diagnosis is approximately 55 years. The clinical findings may consist of pruritic erythematous violaceous papule, which are flat-topped, small, angular, only few millimeters in diameter. Sometimes large plaques covered by fine blistering scales can be visible. Surface is covered by a characteristic of very fine grayish white lines called Wickham striae. Occur mostly as a bilateral symmetrical pattern on the flexor surface of the wrist or forearms and the inner aspect of knees and thighs also. The primary symptoms may include classic skin lesions can be described as purplish polygonal planar pruritic papules plaque. The reticular form characterized by fine white lines or striae. The striae form a network also shown as an annular or circular pattern most frequently observed bilaterally in the mucosa. Papular form includes a papules characterized by small white dots. The bullous form is unusual, clinically resemble as a erosive lichen planus. Plaque-like form homogeneous, well demarcated white plaque surrounded by a stage similar to homogeneous oral leukoplakia, most often encountered in smokers. Erythematous or atopic form is characterized by homogeneous red area present in the buccal mucosa or palate. Striae are frequently seen in the periphery, exclusively affecting the attached gingiva present as ulcerative form, disabling form of oral lichen planus, fibrin-coated ulcers surrounded by erythematous zone, frequently displaying radiating white stain. Differential diagnosis includes lichenoid reactions, lichenoid drug eruptions, oral graft versus host disease. Lesions is usually generalized in graft versus host disease, frequently seen simultaneously with xerostomia, presence of localized skin involvement, and liver dysfunction. Management includes just typically symptomatic topical antifungal therapy with clotrimazole 1% cream thrice a day for a week can be given. Relief in symptoms, asymptomatic, regular follow-up should be done. If there is no relief in symptoms, the new cases of the topical corticosteroids of triamcinolone acetonide 0.1% thrice a day until the symptoms improve could be given, or fluconazole acetonide 0.025% or clobestrol propionate, clobestanol 17 butyrate can be given. If there is a recalcitrant cases, intralesional steroids of intralesional triamcinolone 0.5% with once a week for 4 weeks can be given along with immunomodulators, chloroquine 250 mg twice a day for 3 months, and immunosuppression also given. Azithromycin 1 mg per kg of the body weight can be given. In additional to this, poor therapy can be given. Newer drugs like mycophenolate mofetil 500 mg tacrolimus sirolimus can be tried. If there is a relief in the symptoms after topical corticosteroids, combination therapy of tablet prednisolone 10 mg, viasolone, which is called viasolone or imisolone, thrice a day for 2 weeks can be given. Topical triamcinolone acetonide 0.1% improve thrice a day till symptoms improve, or cyclosporin solution as a mouth rinse for twice a day for 15 days. Drug-induced lichenoid reactions. Lichenoid reactions were differentiated from lichen planus on the basis of administration of drug or contact with metal, use of food flavoring substance, or systemic disease resolution when the drug or other factor was eliminated. Clinically, lichenoid reaction may exhibit the classic appearance of a lichen planus, but atypical presentations are also seen. Clinically, drug-induced lichenoid reaction may resolve when the drug is eliminated. Clinical findings, usually unilateral ulcerative reaction pattern. Oral lichen planus and lichenoid reaction should be considered clinically indistinguishable. Lichenoid drug eruption appears similar to lichen planus and may be severely pleuritic. Diagnosis: it compresses white reticulum or papules concurrently with erythematous and ulcerative lesion. A correct diagnosis is easier when the patient develops drug-induced lichenoid reaction after starting a new drug. Management: discontinuance of the drug and symptomatic treatment with topical steroids. Lichenoid reaction of graft versus host disease, complex multisystem immunologic phenomena characterized by interaction of the immunocompetent cells from one individual to the host, etiology and pathogenesis. Major causes allogenic and hematopoietic cell transplantation. Clinical findings occur in both acute and chronic graft versus host disease, indistinguishable from OLP, associated with more widespread involved in the oral mucosa, involves cheek, tongue, lips, gingiva, fine reticular pattern of white striae resembling to OLP is evident, which also cause burning sensation of the oral mucosa and xerostomia. Diagnosis: presence of systemic graft versus host disease facilitates the diagnosis of oral mucosal changes of chronic graft versus host disease. DD includes candidiasis, toxic reactions to chemotherapeutic drugs, unusual viral infections like not reaction management, same as that of OLP, topical steroid preparation, fluconazole, and clobestrol propionate gel can be given. Patients with history of graft versus host disease should be examined for oral malignancy as a part of the medical follow-up procedure. Lupus erythematosus represents the classic prototype of autoimmune disease involving immune complexes. Clinical findings are observed in SLE, systemic lupus erythematosus, and discoid lupus erythematosus are similar in their characteristic, both clinically and histopathologically. The typical clinical lesion comprises white striae with radiating orientation, and this may be sharply terminate toward either the center of which has more erythematous appearance. Most common sites are gingiva, buccal mucosa, tongue, and the palate. The lesion in the palatal mucosa can be dominated by erythematous lesion where white textures may not be observed. Oral mucosal lesion compatible with lupus erythematosus may be first sign of the disease. It compresses a well-demarcated cutaneous lesion with round oval erythematous plaques or scales and follicular plugging. The lesion may form butterfly-like rashes over the cheek and nose, known as a malar rash. Management: when the symptomatic intraoral lesions are present, topical steroids should be considered, such as clobetasol propionate gel 0.05%. The treatment begin with application 2 to 3 times a day, followed by tapering next to 6 to 9 weeks. Minimum use of immunosteroids to obtain the relief. Immunosuppressive drugs used to treat the lupus erythematosus may precipitate opportunistic fungal and viral infections, which are part of the and chlorhexidine. This is a lignite contact reaction. It occurs due to delayed hypersensitivity constituents derived from the dental materials like. Clinical findings include delayed hypersensitivity reactions to amalgam fillings, same reaction pattern, same as oral lichen planus. The major difference between oral lichen planus and lichenoid reaction is the extension of the lesion. It is non-symptomatic. The diagnosis include replacement of the dental material may assist to discriminate between lichenoid reaction and oral lichen planus. Management includes replacement of the dental materials resulting cure of 90% of the cases. Reactions to dentifrice and chlorhexidine. It is a rare allergic reaction to flavor additives such as caravan and cinnamon or preservatives. Clinical findings: fiery red erythematous and edematous gingiva include both ulceration and white lesions. Involves either other sides of the labial, buccal, and tongue mucosa. Healing seen after withdrawal of the allergen containing agent. Toxic reactions to smokeless tobacco and smoker's palate. Clinical findings: smokeless tobacco is divided into three different groups: chewing tobacco, moist snuff, and dry snuff. Mildest form, the lesion noted as wrinkles at the site of application. High consumers may display a white and leathery lesion. Gingival retraction, most common adverse reaction seen in the smokeless tobacco habit. Smokeless tobacco products contain nitrosamines, polycyclic hydrocarbons, aldehydes, heavy metals, and polonium. Smoker's palate: dark brown pigmentations of the oral mucosa and a white leathered lesion of the palate. Red dots can be observed representing the orifice of the accessory salivary glands, more prevalent in men, common in high consumers of pipe tobacco, cigarettes and reverse smoking. Etiology is related to high temperature in the palate. Reactions to mechanical trauma, morsicaceobaccarum and frictional keratosis. Morsicaceobaccarum is instigated by habitual chewing. This parafunctional behavior is done unconsciously and is therefore difficult to bring to an end. Morsicaceo is most frequently seen in the buccal and lip mucosa, 3 times more common in women. Management is by assurance. Frictional keratosis characterized by white lesion without any elements observed in areas subjected to increased frictions. Etiopathogenesis, increased abrasion stimulates the epithelium to respond within an increased production of keratin, regarded as a physiologic response to trauma. Predisposing factors are smoking and alcohol. Clinical findings seen in edentulous areas of the alveolar ridge, mostly asymptomatic management, no surgical intervention, reduced predisposing factor. And white lesions, any other white lesions includes benign migrating glossitis, which is geographic tongue, leukoedema, white spongy nevus, hairy tongue. Benign migratory glossitis, benign inflammatory condition of the mucosa with map-like areas of erythema which are not constant in size, shape and location. These are the synonyms of geographic tongue. The clinical features include circumferentially migrating and leaves like an erythematous area behind, reflecting atrophy of the filiform papilla. The peripheral zone disappears after some time and healing of the depapillated and erythematous area starts. The lesion may commence at different starting points. The peripheral zone fuse and the typical clinical features of the geographic tongue emerges. Depending on the activity of the lesion, the clinical appearance may vary, single to multiple lesion occupying the entire dorsum of the tongue. Disappearance of the peripheral zone may indicate that the mucosa is recovering. Management may regress, but it is not possible to predict when and to which patient this may happen. The prevalence of this disease seems to decrease with age, which supports a spontaneous regression over time. Leukoedema, a white and veil-like alteration of the oral mucosa, considered as a normal variant. Etiopathogenesis is not clear. Clinical feature, bilateral in the buccal mucosa, less clinically evident after stretching the mucosa. Asymptomatic diagnosis, gentle stretching results in temporary disappearance. Management, no treatment. White spongy nevus, autosomal dominant disorder, etiopathogenesis, mutation in the genes coding for epithelial keratin, epidemiology, rare disorder, 1 in 2 lakhs, may present at birth or appear in childhood or in adult life. Clinical features, avoid elevated lesion with irregular surface, compressing fissures or plaque formation. Affected sites are most common in the buccal mucosa. Mucosa appears to be swollen, white, spongy and leathery, asymptomatic. Hairy tongue, etiopathogenesis unknown. Predisposing factor, neglected oral hygiene, shift in the microflora, antibiotics, immunosuppressive drugs, oral candidiasis, excessive alcohol, conception of the oral inactivity and therapeutic irritation. Clinical features, impaired desquamation of the filiform papilla leads to the hairy-like clinical appearance. Elongated papilla, length of more than 15 mm have been reported in hairy tongue, found in the posterior one-third of the tongue, colors from white to black. Management, reduction or elimination of the predisposing factor, removal of the elongated filiform papilla. This completed the red and white lesion part 2 and thank you.